You. Jyoti ma'am, good evening. Jyoti ma'am, have you logged into two systems? Right. Be careful, you can't get out. Good evening, Anita madam.
Good evening, Saji. How are you?
I'm good, ma'am. How are you?
People are joining in. I don't see.
It's raining here.
Just is it? Have you intimated the delegates?
Yeah, I informed them. Madam will be joining.
Dr.
Vasant sir,
Vasan, Dr. Okay.
Vasant sir, I'm not able to reach him because he's traveling. Yogesh sir and
Okay.
Atanu sir are in a program, but they will join. Basuraj sir also, I will just call up and confirm.
Thank you.
Thank you.
Amongst the speakers, I've intimated Dr. Sunila. I'm yet to see her join in. Good evening, Dr. Sunila. Welcome.
Good evening.
I'm just waiting for it to really clock 4 o'clock, and I'll just
Fine.
check it.
Should I just check whether screen sharing works or any issues? I think
Yeah, you could check
that
that
would be a
one.
good idea, right? It will save time later.
Mr. Saji, if you're in, can you please check if
Can you see my screen? I
yes,
think
doctor. You're in, doc.
you can see, right?
Yes. Good evening and a warm welcome to all. I'm just waiting for the IAP president or anybody in the IAP in the panel
Ma'am,
to...
Secretary sir is joining.
Yes,
Yogesh
Mr.
sir and
Saji.
Nathan sir are joining. Yogesh sir and Nathan sir are joining. Neelam ma'am also is joining.
Thank you, Mr. Saji. While we are getting started with the actual CME, I would like to welcome you all and get started with some introductory. I think people are joining it. Okay. Good evening. A warm welcome to all. I am Dr. Vanita. I will be your host and moderator for the day. A brief introduction of CMEs. We have collaborated with, we as in American Mission Hospital has collaborated with IAP, and since October, we are having a monthly sessions of pediatric subspecialty CMEs, ranging from endocrinology to pulmonology. We have covered various subspecialties, and every month we would be covering a theme. Today's theme is allergy and asthma. And we have two eminent allergologists, pediatric allergologists from India and our part of the world. And it sure hopes to be a promising topic for the coming times. So there are recent changes and many changes which are necessary to be updated for a practicing pediatrician in this arena, and it would be a useful discussion for today. I welcome Dr. Sunila. We already met her. I would just wait for Dr. Yogesh and Dr. Neelam before we get started.
I have to say, I may have to drink a bit of water in between. I apologize. My voice is a little bit off.
Not a problem. We are 5 minutes through with our time. Mr. Saji, we will have their introductory note whilst they join it. In the meanwhile, we get started with the event. Dr. Vasant is traveling, is what I heard, and Dr. Ranjan also probably. So we may not hear from them, but as always, their encouragement is not as much in words, but they're always there. So I guess we get started and we can have in between sessions, have them join in. Okay. As I was saying, today's session, the theme is allergy and asthma. As is true with Bahrain as well as in India, at least 40% of our encounter is anything ranging from allergy or asthma. And today we are going to see how one is not separable from the other and how we have to be tuning our practice to be accommodating both and how treating one would be helpful to the other. Uh, as a broad overview, I could speak about it, but I would like Dr. Sunila to emphasize more on this. So I see Dr. Yogesh here. Dr. Yogesh, can you please join in and kickstart the event? I took the...
Yeah. Good evening, Dr. Vanita. I'm here, and our National Treasurer, Dr. Atnu Badra, is also with me. We are here for one infectious disease conference in the city of the Haveri, Karnataka. So just now we have joined. So please carry on. Go ahead.
Thank you,
Please.
Dr. Yogesh.
Yeah, thank you.
We are going ahead, Doctor. Okay, as I was saying, we have actually gotten started with the event. Dr. Sunila. Dr. Sunila Nayak is a pediatrician and with an interest in pediatric allergy and a practicing allergologist from Bangalore. She hails from Bangalore, but has a background from UK too. In Bangalore, as we know, is a common source of pediatric allergies and asthma. So I welcome Dr. Sunila Nayak to get started with the topic. You can see it broadly displayed there, untreated allergic rhinitis. How are we to go about it? There are some legacy concept changes here, and we will listen to Dr. Sunila covering it all up. It's a silent epidemic indeed. Dr. Sunila, please take over and get started with the CNE.
Thank you. Thank you, Dr. Vanita. At the outset, I'd like to thank IAP as well as IAP Bahrain branch, as well as American Mission Hospital for inviting me to join you all and talk about this quite a common and quite, difficult sort of situation where we find that there are a lot of children who have untreated allergic rhinitis, and hence the term is silent epidemic. Over the next 30 minutes or so, I would like to, if possible, go a very quick run through allergic rhinitis, approach to clinical assessment, diagnosis, and treatment, and probably look at pitfalls, and we will discuss a couple of cases. I think that will be what I would like to do if time permits. So going quickly ahead, allergy is, what is allergy? Overreaction of the immune system to a normally harmless substance is allergy. A genetic tendency to develop allergies, which often seen to run in families, is called atopy. Allergic rhinitis is a IgE-mediated response of the nasal mucosa, which occurs on exposed to inhaled allergens in sensitized individuals. Now, in the interest of time, and because we keep talking about this all the time, I'm not going to go into the nitty-gritty of the pathophysiology. We all know when a sensitized individual comes across an allergen, there is cross-linking of the IgE and the mast cell degranulation occurs, and that results in two things, an early phase reaction and a late phase reaction. The early phase reaction, which has a lot of chemical mediators but is predominantly histamine-led, causes the usual signs of allergic rhinitis that we're all familiar with, which is itchy, runny nose, sneezing, and also increased mucus production. They may have itchy red eyes and wheezing too. But also about 4 to 8 hours later, they may end up with a congested, blocked nose with thick, though clear, still thick mucus production, as well as a little bit of runny nose too. So this is what we know. What else is happening? Even when the symptoms subside, if the person is continuing to get exposed to the same allergen, there is something called minimal persistent inflammation that carries on. Now, this is under the symptom threshold, so you don't see or perceive any problems, but there is a constant inflammation of the mucosa ongoing. And because of this constant inflammation, there is hyperreactivity of these nasal mucosa and also the airway as a whole, the lower airways too, as well as the progression. This will lead or, can manifest as a progression of the disease and into a full-blown disease later on in life. So this is quite early where you don't see the symptoms, and then later on they can have symptoms all the time. So the classical triad of runny nose, itchy nose, and sneezing are the hallmarks of allergic rhinitis as we all know it, along with some itchy eyes and wheeze. And the late phase is congested, blocked, or hyperreactive nose. And these, if anybody tells any of you, I'm sure there will be no doubt we will pick it up as allergic rhinitis and treat it too. We are talking about the ones where we miss it, but however, we'll come to that in a bit. So what is the incidence and prevalence of allergic rhinitis? We find that this is now going up quite significantly. It may be a mix of increased awareness as well as increased incidence, but currently we are thinking the prevalence of allergic rhinitis globally is about 35%. That's a large percentage of the population. We are not saying diagnosed, we are talking about diagnosed and undiagnosed allergic rhinitis, which is present in the current population globally. In India, it is about 25% right now, and we are seeing that year on year, there is an increase. We are all familiar with this slide, which shows the atopic march. We know that in an atopic individual, you can get different types or different symptoms of allergy at different ages. And as far as we knew so far, we would say that, in the early stages of life, up till about 3 or 5, you were looking at eczema, food allergies, and maybe asthma. But allergic rhinitis was always thought to be something that a child develops later on in life, maybe as an older child, a teenager, or in adulthood. But what we need to remember is there is a huge overlap between asthma, allergic rhinitis, and the other allergies, whichever ones the child might have, whether it is food allergies or eczema. And all of them are actually have an effect on each other, and a good control means a good control of all the allergies. So this study was done in Germany, looking at children and trying to find out what the impact of allergic rhinitis is on childhood. As you can see, they have looked at different things like comorbidity with asthma, whether it's disturbing their daily activities, and conjunctivitis, also rhinitis. As expected, as the age is older, you see quite a lot. But what I want you to look at is that where it starts as young as possibly 2 or 2.5. And from there, it starts having an impact on the child's everyday activities. They can have conjunctival symptoms, and also it can affect asthma. And it's and also one other thing that I have not mentioned here is sleep and also adenoidal hypertrophy, mouth breathing and upper airway obstruction. So how do we find out, and what do we know? How do we find out if a child has allergic rhinitis? As in everything, history is king. History is possibly the most important thing that we could do in allergy, and without history, we get nowhere. And even in history, most of the time we say, don't do leading questions in history. But here we possibly, initially you will ask an open-ended question and ask what is causing, what has brought them to the doctor, and what their concerns are. Once they have finished, and if you think there is a chance of allergic rhinitis, or if there is any atopy in the family, then do ask leading questions, because quite often neither the child or the parent don't think that it is significant enough to tell you about that little runny nose, which is there only for a few, half an hour or so in the morning, or the fact that they sneeze in the morning, he rubs his nose, which is thought to be more of a bad habit, or mouth breathing, again thought as a bad habit. You need to ask these, specifically. Not only do you ask them, you also ask, when does this happen? Does it happen at a certain time of the day or a certain time of the year? When it happens, how long does it take for you to get better? Where does it happen more often? Is it indoors, outdoors? And possibly, if you can go into the details of triggers, you can ask. This is a little bit tricky because most people will tell you I am allergic to dust and also a whole long list of food that the child can't have or is allergic to. Generally not true, but stick with them and ask. And then if you can go into the a little bit more detail and ask about specific triggers where their allergies are more, then you might find a little bit more information. It is also very important to know what other atopic history the child has, as well as any family history of atopy, which will tell you the risk that the child has of developing atopy, and of course, the environment. Allergy is one of the most classical examples of gene-environment interaction. So the same person with the same genetic makeup may develop allergy in one environment and not do so in another. So there are modifiable risk factors which will also help in deciding, well, which will also determine which of the children actually develop allergy. Also ask about comorbidities. Even though the parents may say no, nothing, you will still ask whether the child has any wheezing, any, regular itchy eyes, itchy ears. Children do this, they rub their nose, they sort of rub their eyes. And only if you ask the parents, they'll tell you, recurring headache, earaches, tearing, red eyes, eye swelling, and of course, fatigue, drowsiness, and malaise. Now, all of these are important. ARIA, which is allergic rhinitis and asthma, that committee has come up with a very nice classification of allergic rhinitis, which is based on the duration of the symptoms and how long they persist, whether it is less than 4 days and less than 4 weeks or more than. And based on that, they will make it, they classify it as intermittent or persistent. And based on how much of a disturbance it has in the lifestyle or the quality of life, you decide whether it is mild, moderate, or severe, as it is self-explanatory. Coming to the actual examination. Now, I am not going to go into the complete examination as we would be expected to do in every child. I am only focusing on the allergic rhinitis related findings, because otherwise we won't be able to finish everything. So in interest of time, the things that you want to look for is any clear runny secretions from the nose, allergic salute, which we all know. More importantly, the allergic nasal crease. Quite often I find that you ask all these questions in history, they have said, no, we don't have anything, but you have a child sitting in front of you, or even a baby sometimes, who's sitting in front of you with the allergic nasal crease. Even babies seem to rub their nose on the bed or whatever they can find on their parents' shoulders or wherever, because the nose is itchy. So even in the as early as second year of life, you can have allergic rhinitis. Around the eyes, you can have the Denny Morgan folds and also the allergic shiners, which is due to congestion of the venous congestion around the eyes, secondary to allergic rhinitis. Going on with the examination, always, always, always look in the nose, because what you're looking for is the inferior turbinate. Quite often you find a pale boggy turbinate with a watery discharge, which is there, and it's just sometimes even looks almost bluish in color, and that is quite typically found in allergic rhinitis. The child may have no other symptom. They may have enlarged tonsils, not inflamed. This is not the right picture, but enlarged tonsils is what this was supposed to show. And in a child where there is quite significant blockage or significant postnasal drip, they will have what we call a cobblestone pharynx. It literally looks like cobblestone with ups and downs. And this is something you have to specifically look for. And if it is there, your clinical diagnosis becomes more, you are more confident in your diagnosis. Not only do you look at the nose and the signs of allergic rhinitis, you look at the comorbidities too. You examine the ear to look for any serous otitis media. You look at the skin. Is there dry skin, any, atopic dermatitis, the signs of scratches or scratch marks. Look at the mouth, the facial, the malar hypoplasia. They have a slightly ingrown jaw with a crowding of the teeth, or around the eyes and inside the eyes too, where they might have allergic conjunctivitis. These are all very important findings, and they will, each one will add more, help you make a robust diagnosis in whatever it is that you're going to see. So it is a clinical diagnosis. So allergic rhinitis is a clinical diagnosis. So unless it is very vague, It is usually you can, at the end of history and examination, you can make out whether you are dealing with allergic rhinitis or not, but you will not be able to make out the cause of the allergy or the root, the trigger of the allergy just by clinical diagnosis. Though you may suspect based on the diurnal and the seasonal pattern, you may suspect what might be causing it. To give you a definitive diagnosis, you will need to go ahead and do allergy testing. And in allergy testing, the gold standard allergy test is a skin prick test. Here, you put small amounts of allergen extracts on the skin and do a very superficial epicutaneous scratch on the surface of the skin. And after some time, you see a reaction in the place where there is a actual allergy sensitization. This we call sensitization rather than allergy. This is relatively painless, very quick, inexpensive, and also a visual reiteration to the family as to what is happening when this child's body comes in contact with that particular allergen. What are the problems for the skin prick test? You cannot do a skin prick test if the child has taken antihistamines between 5 and 7 days before the skin prick test is done. You need healthy skin. Also, obviously, you need training to do the skin prick test. So, what is your alternative? Alternative for this is a blood test, which is called serum specific IgE. Now, the advantage of a serum specific IgE, it can be done on anyone and anytime. So even infants, pregnant women, whoever, you can do it. You don't need any additional training. It's a blood test. So even the patients are familiar with the concept of a blood test. You can do it in even a very severe atopic dermatitis. So your skin condition doesn't matter and you don't need to stop any medication. What is the downside of a blood test? In population where the total IgE is generally high, as in India, and you may have a higher incidence of false positive. You also need to have a good idea of what you're looking for and test those relevant allergens, and the availability of that allergen-specific blood test is also important. It is usually more expensive than a skin prick test, and of course, the results take time to come back. The biggest problem I feel is that there are plenty of unvalidated tests and panels for allergy across all labs. I don't know whether it's the same in Bahrain, but here in India, there are so many that quite often the tests that are done are not really interpretable. So always choose a validated test, such as right now, the gold standard with the most scientific backing is the ImmunoCap. The second one, which is very similar, is ImmunoBlot. There is another blood test which is available now, but I would highly recommend that this is not done by anybody who is not trained in allergy and not trained in interpreting it, because it is truly a can of worms, and once you open it, you cannot put it back. So that is called component resolved diagnostics, and it has specific indications, and I wouldn't do it unless you know why you're doing it and what you're looking for and how to interpret it. Whenever you have a test result, always interpret it with history in context. A test is positive is only indicative of sensitization, but if that sensitized individual has a correlating history, the history matches with what you suspected, the test matches with what you suspected in history, it is called allergy. So now that we know that this person has allergy, what do we do? Treatment can be non-pharmacological and pharmacological, generally done together to achieve best result. The biggest and the most important thing you can do is the patient and the parent education. Because unless you do this, whatever result, whatever treatment you give, it's going to be not done or followed through, because this is a chronic condition. Quite, it comes and goes and it can have flare-ups. So you need the patients to know why they're doing what they're doing, and hence be able to continue and continue on the treatment that you prescribe. Once you have done a specific allergy test, you will know what the child is allergic to. So you can then advise allergen-specific avoidance measures. There are also lifestyle changes which we know modify the risk factors. So for further allergy progression, that will help. Intranasal saline, though not a true pharmacological agent, is really, really helpful, whether it is in the form of a spray, douching, irrigation, whatever. There are many studies across adults and children which show that it is very beneficial. Of course, it is low cost and it has next to no adverse effects if used properly. The actual pharmacological treatment or medication, there are many, as you can see in the list, and most of you will be familiar with all of these actually, and would have used most of them at some point or the other. And of all of these, the cornerstone of pharmacological treatment in allergic rhinitis, if you have to remember only one thing, that is intranasal corticosteroids. And why would you want to do that? These are the different symptoms of allergic rhinitis, as you can see. And these are the different pharmacological agents. And as you see, that is the only thing that really helps across the board and also has a very good safety profile. If you use other things, they're either very temporary, they don't have much of a safety profile, they can have other issues. So I would say, if you have to remember one thing, it is nasal corticosteroids and the technique of how to administer it. Everybody is worried. Why then? What is the problem with the corticosteroid? That's the other thing, isn't it? Because it takes time for the patient to perceive that it is working. So it takes almost 2 weeks for it to set in and start showing effect. And in that time, it is very important that they are patient enough, and they will be, if you counsel them before you start, that this is what is going to happen and it's going to take time before you can feel the difference. And in the meanwhile, you can give them an oral antihistamine to just, have symptom control. So most of the time, whether it is doctors, the physicians or patients, they are worried that these are steroids. And so the long-term effects of having this. And as you can see here, if you choose the right kind of intranasal steroid and it is administered correctly, the systemic bioavailability is next to nothing. And you're not just telling them, take these steroids and go away. You are going to find out why they have an allergy, what they're allergic to, and how to avoid it or treat it. And that brings us to the actual treatment in allergic rhinitis, where you find out what the allergen is. Here, allergen-specific immunotherapy is the treatment of choice, where you know what the specific allergen is. Here, we give increasing concentration of the specific allergen, and it is given such that it induces tolerance and desensitizes the patient. The two commonest modalities practiced are subcutaneous and sublingual immunotherapy. This has been shown to be highly efficacious. It has been around since 1911, and there are several studies, and study after study shows that it is very, very efficacious and is the only treatment which has a disease-modifying effect. Not only does it do that, it also prevents progression of rhinitis to asthma, which we know 50% of children with rhinitis will develop asthma if left alone. Also, neosensitizations, where new allergy formation is also reduced. The risk of neosensitization is reduced. The other thing is that most of the other medication, you stop the medicine, all the symptoms keep returning. Whereas here, there are sustained benefits even after discontinuation, and this may be years after discontinuation. So what is the problem, and why do we not do it for all? Well, one, in a child who qualifies, it should always be offered. But the main problem that we come across is compliance, wherein because it is a 3 to 5 year treatment, it's a minimum 3-year treatment, compliance for that duration seems to be the main challenge for giving allergen-specific immunotherapy. So I am not going in detail here, but I just wanted to mention there are 2 very nice flow charts in the ARIA guidelines where they tell you exactly how to assess, what treatment to start, and when to progress. Just like how we have in the GINA guidelines, it is here, and you can just follow it. It starts with intranasal corticosteroid, and then eventually considering allergen-specific immunotherapy. So there are 2 charts, one for treated individuals, one for untreated symptomatic patients. Okay. So far, allergic rhinitis approach, diagnosis, treatment, it looks fairly straightforward, doesn't it? Shall we see how it works? So I'm just bringing you to a case. This was a little girl I saw a few years ago. I used to also do pediatric endocrinology as I was duly trained. And this child was referred to me for short stature. She was known to have asthma. She was diagnosed and had started treatment with inhaled corticosteroid as well as SABA. Very compliant. But despite this, since she had started her symptoms in the 2nd year of life, she'd had many episodes where she needed frequent nebulizers and she was really poorly controlled. She also loved to dance and was learning Bharatanatyam, but was unable to because she ended up coughing when she danced. She also continued to have nocturnal cough despite being on the inhalers. Her sleep was quite disturbed. She was smallest in her class and had poor growth, which is why she was seeing me that day. Parents were really worried and were at the end of their tether with this very ill child. So in history, I asked a few other questions. I asked them any allergies, and they were saying, I don't think so, doctor, but we don't give any banana, any of the cold food that they perceived as cold food. We only give her hot or warm water. We have tried everything, but not working. Anyone else with allergies in the family? No, nobody. No, everybody is fine. There are no allergies at all. But on further digging, father said, oh yeah, I do have a sinus problem. And I did seem to get a cold all the time when I was little. But no, I don't have any allergy. So no diagnosis given. The child herself, she was a bright, happy little girl. She was small for her own age and for her parental centiles too. As you can see, the parental centile is here. And one thing that I noticed was she was constantly keeping her mouth open all through the consultation. Not once did she breathe through her nose. So on examination, I found that she had quite a clear, her chest was very clear with no wheeze, no hyperinflation, but she did have a very clear horizontal nasal crease. She had pale, boggy inferior turbinate. There was a clear watery secretion on both sides. And also her pharynx showed quite significant cobblestoning with streaks of postnasal drips visible on examination. I went back to history and had pointed questioning. I asked about sneezing. There was none, but she did rub her nose. We keep telling her not to do it, but it's a bad habit. Parents said, does she rub her eyes? No. Does she have an itchy nose or does she make a deep-throated noise as if to scratch her throat? Yeah, she makes a funny noise. Yes. Does she do any mouth breathing? No, doctor, not at all. Only when she sleeps, she snores a little bit. Does she have a blocked nose on waking up or when she is going out? They said, yes, on waking up, she seems to have a blocked nose, but very quickly, as soon as she goes, brushes her teeth and has a shower, she's all right. Within half an hour, she's okay. So we don't think it is important. Does she have any nighttime cough? And if she does, what time does she cough? Is it as soon as she goes to sleep within an hour or so, or does she cough in the middle of the night or early hours? They said it can be both. She can cough any time of the night, as soon as she sleeps, middle of the night, waking up, all the time. So at that point, I gave her a diagnosis of allergic rhinitis and asthma. I couldn't really classify it further because they didn't seem to have any history to tell me about intermittent, persistent, any of that. But she was continued on her inhaled corticosteroid, as well as she was started on intranasal corticosteroid. Both the techniques were demonstrated and checked, and she was advised to have an allergy test. She came back for the allergy test, which showed dust mite sensitivity. I don't know if you can see it here. There are two wheels for the two dust mites. And she was advised, the parents were advised on avoidance measures. And after discussion with parents, we started sublingual immunotherapy for dust mite. And within 6 months to 1 year, there was a remarkable improvement in her symptoms. She now did not need any SABA at all. Her Budecort dose had now got reduced to about 1 puff once a day. And she continued on the nasal spray, 1 spray for each nostril, once daily. 2 years down the line, this was year 3 of her sublingual immunotherapy, and they were very compliant. She was now sleeping well. She was no longer breathing through her mouth, and she was completely weaned off her inhaled corticosteroid. And they could not remember when they needed to use the SABA or the nebulizer in the last time. She still needed some intranasal corticosteroid when she visited her ancestral home, and that was only 1 or 2 weeks a year. But parents were very quick to recognize symptoms and early treatment was started. She now is dancing regularly and enjoys dance and has no problems at all. And the cherry on the cake was that her growth parameters improved. So if you can see, it improved quite significantly, and now she was back in the parental centile range. So this child had untreated allergic rhinitis with none of the symptoms that I first told you, the triad of sneezing, itchy nose, runny nose. She didn't have it. We had to go in and ask and find out with, leading questions and digging the history a bit more. And that was only done because she was very poorly controlled, which shows that allergic rhinitis, if untreated, can exacerbate and worsen asthma. So why do we miss it? Because just like this family, they didn't think it was a big deal. It was not abnormal. She had much more things to, greater things to worry about, like the wheezing, like the, inability to sleep. She was not growing. Those were all much bigger deals than this little bit of a runny nose or a blocked nose when she wakes up. Not just the parents or the physicians, even children themselves don't think it is important. And quite often, every time it happens, it is put down to something. She was in the rain yesterday. She ate something cold yesterday. She had milk yesterday. She had curd yesterday, one or the other thing. So they're all blamed on something or the other. So you are required to ask pointed questions, because it is not as straightforward. And this is because it has so many comorbidities. And allergic rhinitis, even though it starts early, it has the subtlest symptoms of all. And unless you really make an effort to ask, you can very easily miss it. So this is a condition which is hiding in plain sight. And unless you are actually looking for it, you will miss it. So please think of it. So what happens if we don't treat allergic rhinitis appropriately? There was a study that found that almost 90%, that's a huge percentage, of allergic rhinitis is either inadequately or inappropriately treated. How is it inappropriate? It is because either one, we don't start it early enough. Even if we start, we give very little, so we don't treat it adequately. And quite often, rhinitis symptoms, just runny nose, it's ignored unless it starts causing real problems in the lifestyle or quality of life. These symptoms are ignored. Also to remember, quite often in children, we see a lot of mouth breathing and adenoidal hypertrophy, and we are quite good at recognizing and picking up adenoidal hypertrophy. And quite often, these children are sent to ENT. They're found to have big, large adenoids, frequent infections, and so they go on to get adenoidectomy done too. Chronic nasal inflammation, which is seen in allergic rhinitis, can also enlarge adenoids, and 38% of children who have adenoidal hypertrophy are associated with allergic rhinitis. Because both have very similar symptoms, it is really tough to pick or tease out one from the other. But the important thing to remember is that 30% of children undergoing adenoidectomy will have persistent symptoms if their allergic rhinitis is not treated. So it all comes back despite surgery. What is the other thing? Almost 60% of children with allergic rhinitis report eye symptoms. But these are again not, unless they are really severe, they're not really taken into account. Many times they are treated as infection with some antibiotic eye drops, but the child keeps itching their eye, and this itching can lead to a lot of problems on the cornea, and this can end up in shield ulcers, which can be sight-threatening, and they're at high risk of astigmatism and keratoconus, depending on what sort of allergic conjunctivitis they have. If only the eye is treatment and allergic rhinitis is not treatment, they can have problems due to the medication for the eye itself. So early recognition of, even when they have conjunctivitis, go and look for allergic rhinitis. And if it is there, early recognition and adequate treatment can prevent complications for both the eye and systemically too. So other consequences of untreated or poorly treated AR. In children, of course, we have learned that it makes asthma worse, whether it is control, severity, or exacerbations. Much greater economic costs. They have much more, they keep needing medication. They have to visit hospitals or physician often. And quite often, if they're really sick, and that they are quite often, they have school absenteeism. In adults, it was found that people who had untreated allergic rhinitis or who would take over-the-counter antihistamines were far more compromised than people who had a blood alcohol level over the permissible limit. So motor car accidents have been implicated in untreated allergic rhinitis and antihistamine use. And also in children, remember, it affects their school performance. They feel sleepy in the morning, they are tired, and this will affect their confidence and hence overall their emotional well-being too. So it has far-reaching issues rather than just the nose. Quite often, when they're not, because they don't think the symptom is very important, what do? They reach for the thing that they can easily access, and that is an antihistamine. Even though there are newer second generation and higher generation antihistamines, the first generation antihistamines are still quite prevalent and are used, but these have much more problems than benefits. They have fatigue, sleep problems. It affects the cognition, and also it reduces their ability to learn in school. So sleep loss, daytime fatigue is very commonly seen. So in all children and adults, non-sedating second generation antihistamine is preferred for treatment of all allergies, including allergic rhinitis. As you can see in this, the first generation are the ones which have the greatest effect on the brain receptors. And as you go further down, and the higher ones have the less effect, with the fexofenadine and belastin being the least effect on the blood-brain, crossing the blood-brain barrier or effect on the brain. What about topical nasal decongestant? This is the other one which is easily available, at least in India, very easily accessible over the counter. The advantage that the patient perceives is the rapid relief of their nasal congestion. They can't breathe, they can't sleep, they just put this one drop and it's magic. But unfortunately, this causes a vicious cycle of physical dependence and leads to rhinitis medicamentosa in quite a number of patients if they're using it regularly. This is used for any nasal condition, and the pharmacists don't think twice before they hand it over. Sorry. In people who have recurrent seasonal symptoms, they have, even today in some parts of the world, a pre-seasonal intramuscular corticosteroid is given. It is unfortunate, but it is done. But intramuscular corticosteroid injections are definitely not recommended and highly discouraged. They have a high risk of side effects. And if at all you need to give systemic corticosteroids, it will be in the form of oral corticosteroid, no more than 5 days at a time. And this seems to be relatively better and free from significant adverse effects. But remember that cumulative lifetime dose of OCS is also found to have a significance when you're looking at loss of bone mineral density and other effects of systemic corticosteroids. So now we come to the second case. I don't know how I'm doing for time. If you will allow me, I can just quickly run through this second case. I just saw this child 2 weeks ago, and I thought he was very relevant. Can I continue?
Please go ahead, doctor.
Yeah. So this is a 15-year-old boy who came in with a very troublesome respiratory problems. His main problem was that he's having difficulty breathing and he's unable to sleep because of his nasal congestion. He's had these problems going on for quite some time, but he's always, managed to control symptoms with over-the-counter medication like either oral nasal decongestant or oral antihistamine, which he's self-medicating. He did see an ENT doctor once who prescribed fluticasone nasal spray, but because it's a steroid, the family got worried and they took it for about 15 days and then stopped. He much prefers oxymetazoline because it is rapid relief, but now he's been taking it every day for a month, but not getting enough relief. Moreover, he's now in 10th standard and the family want it sorted. Past history. Parents told me that he caught anything and everything going around. He had very frequent upper respiratory infections. As a toddler, he used to wheeze. He was treated with nebulized medications and antihistamines on an as-required basis. They started avoiding cold foods quite early in life, but he still continued to cough and it sounded wet. Around 5 years, he started snoring quite significantly, and he had grade 2 to 3 adenoid hypertrophy and underwent an adenoidectomy at that point. It seemed to give him temporary relief, but all those symptoms came back after a year. He was started on inhalers at 6 years because his wheeze was still a problem. Despite this, he was occasionally very wheezy and was being nebulized at home. He does have early morning sneezes and congestion, but he doesn't think it's a big deal because it gets better in about an hour. In his family, dad had a transferable job. So they were moving city every 2 to 3 years. And even more, they were moving doctors. They were going to different doctors each time. So they didn't have anybody overseeing his health. And also, I don't think they went when the child was well. They always went in an acute situation where the acute condition was treated and he was sent back. He did see a couple of doctors who tried to put in, like the ENT person who gave the intranasal steroid, but they were worried, so they didn't use it. Mom said she doesn't have any allergies, but has a sinus issue. Paternal uncle has asthma. This boy apparently was a very good swimmer and was very keen on swimming, but with his adenoids becoming big, ear infections occurring, and him getting a cough and becoming out of breath, they stopped him from swimming. Currently, he predominantly is an indoor person who reads and prefers to play on his PS4. Again, was an excellent student, but now he's getting frequent headaches, he's feeling tired all the time, and is struggling at school too, and doesn't feel like going out or doesn't feel like meeting people because he's always feeling heavy head. So the timeline of symptoms in this child, as you can see, started at 2 and he's now 15. All I wanted to say here is look at the number of missed opportunities we've had. If at any one point, I'm not saying this is anyone's mistake because circumstances were such, he was moving from doctor to doctor and between different cities. Surprisingly enough, there was no difference in his symptoms, though he moved from different cities, whether it was warm, cold, he was having symptoms all through. But this is what I'm trying to say. His allergic rhinitis possibly started here and could have been diagnosed with a skin prick test, and his avoidance you could have started avoidance pretty much straight away, even at 2 years of age. And also intranasal steroid is licensed from 2 years of age. If we had done that, we would have possibly, put the brakes on the disease progression, and he may not have ended up where he is today. Okay, we have not done there. We come here when he starts wheezing. Again, all this food avoidance will lead to nutritional deficiency. He's having intermittent antihistamines, nebulizers. They didn't mention corticosteroids, but they didn't have any notes. I have no idea whether he was given any. Again, a good opportunity to have sat down, taken a history, and maybe done testing and started treatment at this point. Allergen-specific immunotherapy is licensed from 3 years of age, but generally we start around 5 years. And so between this and this, he could have even started immunotherapy if it was needed. Again, adenoidectomy, that's fine. We don't know the circumstances, but quite often if you give a prolonged course of intranasal steroids, your adenoids do become smaller and you don't always need an adenoidectomy. And again, a testing and immunotherapy might have altered the rest of the course. And it's the same story here. If you look here, by this time, he has had a red eye and on and off headache. So he sees the ophthalmologist who tells him that he has astigmatism and he's been now prescribed glasses, which he's going to have for the rest of his life. And this astigmatism, the chances are that he had quite significant eye itching intermittently, where he has really rubbed his eye, which has caused changes in the corneal curvature. So by this time now, he's now gotten into the vicious cycle of nasal decongestant. And by the time he presented to me, he had rhinitis medicamentosa and everything else that we have just discussed. So this boy actually highlights how we can actually intervene, and if we don't intervene, where we end up. So this boy, we did an allergy test. He was sensitized to dust mite, storage mite, and cockroach. Avoidance measures were initiated pretty much straight away. He has been started on nasal saline douching, intranasal corticosteroids, and antihistamine combination, as well as oral antihistamine. I have discussed allergen immunotherapy. Parents are keen to start, but we want his current medicamentosa symptoms to settle down before we go further. And with that sensitization, dust mite and storage mite, it is very good response that we expect from immunotherapy. So my only ask is think about allergic rhinitis. Ask leading questions about specific symptoms. Examine the nose in every single child and recognize the signs. Routinely ask about symptom control in other allergic conditions when you're following them up. and provide advice about minimizing known triggers and also modifying lifestyle. Allergen immunotherapy is the treatment with the most evidence and the only disease-modifying treatment. Thank you. If you have any questions, I welcome those. Sorry about running over time.
Thank you, Dr. Sunila. That's question time. After we would really sit through some more time after the next talk. Thank you very much. It was really an eye-opener how we dub allergic rhinitis as a very benign thing and how it has an impact on a whole lot of things, ranging from the school performance of the child to the growth and development. It was indeed an eye-opener. So there was some concern that the two topics have a lot of overlap, but then as we discuss, it would be useful to reiterate a lot of points so that we take home practice points. So in the meanwhile, I did see Dr. Neela Mohan. Doctor, if you're around, as always, we would be happy to have your insight before we move to the next speaker. Dr. Neela? I did see her joining us. Dr. Sunila, you can stop sharing by the time I get our next speaker. Okay, I did not see Dr. Neelam over here. Okay, nevertheless, we move on. Dr. Manal, can we have you over? Our next speaker is Dr. Manal. Welcome, Dr. Manal. We are meeting for the first time. Let me introduce you to Dr. Sunila, fellow allergologist from our part of the world.
I'm having a bit of technical. Hello, hi.
Hi, doctor. We don't see you online.
I know. Just one
I
second.
urge all the participants to have their questions jotted in the QA or chat box.
Oh, God.
We will address all the questions at the end of the next session.
Just let me.
Dr.
Hello,
Manal, while she's
you can hear
joining
me?
in, let me introduce.
You can hear me? Yeah, now. Okay, yeah, let me just open the video.
Thank you, doctor. We don't see you sharing as such.
I'm trying.
Yes, I understand.
Can you see me now?
No.
Okay.
We can hear you. We don't
Yeah,
see
I'm
you in the
trying.
screen.
Let me just open the video.
While Dr. Manal is...
I'm really sorry. Let me call assistant.
It's fine, doctor. Please take your time. I'm not sure where the hitch is. Otherwise, I would have helped you. I think you just have to sign in and...
Shall I answer the questions while we are waiting?
We would rather be good.
Okay, that's all
moving. Okay, you can answer the questions in the
I
chat
see one
box,
question in the
doctor.
chat box. So I just thought, while
Yeah,
as soon as Dr.
you
Manal
could-
is ready, I'll stop. So I think Dr.
she's here.
Dinesh Prabhu has asked, how long can we continue intranasal?
Can you come and help me, Hamza, just with
there is no set time. They are quite safe, but they have to be given in the right way. It is always, you advise it to be given to the lateral wall of the nasal cavity. So never to the medial, not towards the septum, but away. And if it is done in the correct way, there is no end date because it has been found to be fairly safe. Having said that, we don't ever say take it forever. We give it and we reassess, and based on the response, we can keep changing and reducing. It may be that they need it only in certain seasons. It may be that they need it only at certain times. You can do that. But also, while you've started this, you will do the next step, which is find out the allergen, and if required, start the immunotherapy. Now, your next question is, how is the slit and the skit procedure done? Well, it's not a procedure. It's actually a treatment that is given. So slit is sublingual immunotherapy, where you keep the allergen. It is a meticulously graded dose. So the dose is graded and given slowly. So SCIT is subcutaneous. It's an injection that is given. There is a schedule and you have to follow the protocol. And for the SCIT procedure, for the SCIT injection, they have to come to the doctor's office and they have to get it done there. And initially it is a bit frequent, but then it is quite, once a month, once in 2 months based on what you're using. However, for slit, they can do it at home because it is just a sublingual. It can be in the form of drops or tablet, depending on which part of the world you're in. In the US, and I'm afraid, I'm really sorry, I don't know what is available in Bahrain, but in the US and the West, you get the slit tablets, ready-made tablets that you just eat. They're very hygroscopic. They get, absorbed very quickly. They just get dissolved and absorbed very quickly from under the tongue. In India, up until recently, we didn't have access to the tablet. Now we do. But before that, what we have always used is drops, sublingual immunotherapy drops, which are made based on the sensitization of the child. I hope that answers your question.
Thank you, Doctor. I guess we can continue on with the discussion. Please, can you please stay on whilst we get Dr. Manal on board? Dr. Manal?
Yes, I'm trying my best.
I know. I
Hamza.
noticed that you paused screen sharing. You'll have to press screen share and probably you're in.
Yes, I do. Yeah, I'm trying screen sharing. Am I in now? Hamza, can you try it?
You are. I can see that you are in the domain. You have to press some screen share.
This one, no, not this one, Hamza. This one?
One at the bottom, the green.
This one. Go down, go down. No. This one. Yeah, this one. Yeah. Yeah. Okay, and then get me in the video. Oh yeah, the video's here.
Yes,
You
we are
okay,
in
video?
doc.
Did you see me now?
Yes, we are in doc.
Can you see?
Let me
see me
introduce
here?
Dr.
You can see
Manal in
me?
the meanwhile. Yes, doctor.
It's just, do you want to?
Yeah. Just
You can make it full screen.
Yeah. Yes, I can, of course. Sorry for that.
No problem, doc.
Perfect.
Okay, let me introduce Dr. Manal in the meanwhile. Dr. Manal Allergy is a pediatrician and pediatric allergologist from our part of the world. She has similar profile as Dr. Sunila, and the topic also somewhat having an overlap areas. As we discussed, it would be ever more important to re-emphasize certain concepts which Dr. Sunila touched upon. So the topic is from sneeze to wheeze, rethinking early allergic symptoms. And it's not as benign as we used to think, the allergic rhinitis. It could be an harbinger to asthma. This is the topic Dr. Manal will be covering. And after this, we will take questions. Thank you. Dr. Manal, the floor is yours.
Thank you. Thank you. Thank you for inviting me. This is the first time to participate in this event. And I do have to say I've enjoyed Dr. Sunila presentation a lot. It was amazing. I mean, I go to a lot of conferences, and I think this is one of the most time I like somebody presenting about allergic rhinitis. Is very relevant to our region. Number one, it's up to date, and she just hit the nail on the head. And I promise there won't be a lot of overlap because I did imagine that she will present those issues. So I just tried to take it from there, rather than presenting the science, but in addition, trying to convince audience, because I think the message I got from her is just to think beyond allergic rhinitis, and that early allergic rhinitis can have determinant on child future. Yes. To remind everybody that this is May, the Asthma Day, which is, I think, your event happened quite nicely during the months that we should be focusing awareness campaign about asthma. By the end of this talk, my aim is, and I'm sure most of our expertise, excuse me, just describe, understand the atopic march, and define the clinical progression into food allergy, allergic rhinitis, and asthma. Describe immune mechanism and timing, because timing, as Dr. Sonila said, seems to be quite important. Recognition of an early prediction of asthma, which we call asthma predict index. Identify early life allergic sign linked to increased asthma risk, and acknowledge the significance of early sensitization and family history of allergies. And that's been already talked very relevantly when in the case, I will link that to the cases Dr. Sonila presented. And hopefully by the end of it, we all agree that mild allergic symptoms require early intervention, and that we need really early collaboration on that issue. Our father in medicine, Hippocrates, said, and I often quote him, I think he was way up beyond his time. This man is amazing. Remedies are very appropriate for extreme disease, but early treatment is the best. And here is the slides. I think it's one of the few data about the Middle East, the prevalence of allergic disease. This is quite old, but I think it's this is like 10-year-old, but I think it's still smashing the world benchmark. Allergic disease is very common, as common as 3%, especially asthma and allergic rhinitis, anything from 20 to 3%. That being said, that out of any 10 children, as a family physician or general pediatrician, you have to consider that 3 of them might one of another allergic diseases. And atopic march or allergic march, as a matter of fact, already been, Dr. Sonila spoke about it. I'll speak about its characteristic, that is describe the characteristic sequential development of atopic disorder from infancy through to childhood. Because here I'm trying to speak as an asthma, not as a standalone disease, but a continuum that can be intervened early on, and the lecture before me has set the scene to the highest standard could be. Classically, atopic dermatitis often appear first in infant. Food allergies may follow, leading to allergic rhinitis and asthma. Some people say asthma and then allergic rhinitis. Due from my anecdotal experience and training, I would say rhinitis precedes asthma. The continuum reflection as a pattern, eczema and food allergy typically develop before the age of 2. 1/3 of children with eczema may develop later and to have asthma. Severe infantile eczema is definitely linked to higher risk of severe eczema, and here the story of the flagging gene, because once you have eczema and flagging gene, that phenotype of asthma you're expecting is severe eczema when it comes to adulthood. And here I will just explain, I will not try to go in details. We possibly most of the audience know that when we're speaking about allergic disease, we're speaking about TH2 response, and that in ideal case scenario, TH1 should and TH2 imbalance. But recently, and I can't say well recently, but it's the immune system in allergic diseases and other diseases linked to allergic diseases. People are now talking about even mental health epidemic, definitely things like obesity that is key to the system. So ideally, the treatment should be, any treatment use should be aiming at, if we really aiming at the root, to bring the immune system in balance. And I think we all agree from the Sonila that the only thing can lead to that currently has a role of disease modulation is immunotherapy. And just a quick here to explain that this is a dendritic cell with an antigen presenting cell. So it either, and the idea is that why eczema at the beginning of allergic march? Because in a simple way, Socrates said in the beginning was a word. I'm saying in the beginning was a dry skin. And I always say to my patient, imagine that your skin is cracked with asthma and very dry. This is allow the opening, fine opening, which is another way to tie junction, whether in the skin or the epithelium, to be untied, and then pathogen allergen get into, and then you get the T-naive cell either get into TH1 or TH2, or we get IL-4, IL-5, IL-9, IL-13, And this is our own implication in allergic disease, in allergic diseases. IL-5, as we all know, that associated with eosinophilic inflammation of the airway disease. And here is the tight junction, the beginning of everything. So whether there's a skin barrier defect, and this is genetic, allergen gets in, and then you get here TH2 to TH2, and then you get the TSLP, and then you get the IL-5, IL-13, IL-4-14, you get atopic dermatitis from IL-13, IL-4, and then you get B cells involvement, IgE-mediated diseases, and then you get the eosinophilic and so on and so forth. Here's the eczema, here's the allergic, here's the food allergy. I'm just trying to say this very quickly, and I'm happy to question later on, just to explain that where we're trying to intervene, either here or there. Of course, any disease modality, the lower we aim at the immune system, the better. Because imagine you block the immune system here, you block so many pathways that will open the risk for infection and other diseases. But I think that the race now is to go and block the immune system down, like Dupixent in allergic rhinitis, atopic dermatitis, which prevent asthma. And when you talk about disease modulation and additional immunotherapy, Dupilumab is the only one that has been proven to show some disease modulation test and probably reversal of airway. And here I'm just setting the scene that, as I said, asthma is not a standalone disease. It is a result of event that start early on in life, but unfortunately, the initial window of opportunity is very small, which is the first 2 years of life. This is the international study of asthma, the IAP, which studied asthma actually in 52 countries. One of the biggest epidemiological study, included more than 1.25 million school children. It's a huge study. So as far as we are concerned today, the finding atopic dermatitis as the first step in allergic march is very proven. Prevalence up to 20% of children in some countries have atopic dermatitis. Onset 45% of the onset within 6 months, 60% by 1 year, and actually 80% of people of children or school children by the time they have allergic, they have eczema. And here I join my voice to when we talk about my diseases. The fact that children grow out of it's good news when they get it in the first 6 months, because the child grow out of eczema. But is that the end of story? Do they really outgrow of it, or are a sequential event, even though they grow of their eczema? This is why you have to ask history, and then to examine the child and gear our investigation toward that history. Because the mother will say to you in my clinic, oh, it's just a red rash when he was a baby. And then I ask, was it cradle cat? They says yes, and of course, and I ask mode of delivery, most likely cesarean section, most likely mixed feeding, and then you link the whole scenario. And this is because I've been doing this since training for many years, so I know what to ask. So I'm saying that to practitioners, always the fact that the child has grown for the first step of allergic march of their eczema, or even if it's mild, do not ignore it if the symptom is persistent. Persistent of atopic dermatitis, less than 50% resolve by age 7, and 60% actually stay until adulthood. And I'm sure that a lot of you know that as sometimes atopic dermatitis disappears and then it comes back with a puberty or with breast or with pregnancy, with breastfeeding. And here I always throw my question to pediatrician and sometimes to my well-educated patient. Does children really grow out of their allergy? Is it the fact that he's fine now? Or we need to always, when you go to physician, mention that. The quantitative risk from this huge study that 70% of severe atopic dermatitis develop asthma. 20 to 30% is still 1/3 of even mild eczema patients develop asthma. This is compared to less than 8% of general population. We're speaking about a very robust, respected epidemiological study. And this is the phase 3 of the ISAC. This was published 2012. I think that was like 15 years later when they follow up these children. And here you see those children has 70% have no symptom, but the rest, they do have combination of rhinoconjunctivitis, a bit of eczema and asthma, and the same for the other for the other age group. Here the age group is 6 to 7, and here age group 3 to 14. That tells us really a lot. Now, second of Allergic March. Already, I didn't show Allergic March, but I was expecting that to be shown in the initial slide. You remember dry skin, eczema, and food allergy. And then I come again to that question. Does really children grow of allergy, and it doesn't matter to ask about the history of food allergy? Sensitization to egg in early childhood is a non-risk factor for later development of allergy, sensitization, and asthma. So if the mother said he didn't like egg, he developed rash to egg, that has been taken into consideration. As a matter of fact, the studies has shown that this is a case control study, that 96 children with confirmed egg or fish allergy, and they were followed until school age access to follow observation study using spirometry methacholine challenge. Methacholine challenge is the one that you give a research to give allergen to them. Inhaled allergen by nebulizer, and then they see the airway, how it reacts, of course, under control setting, and then allergy testing. So basically, they monitor these children when they're 7 or 6 year old. I just forget the age number. They definitely will be above 6 because they did spirometry, they did methacholine challenge, and they did allergy testing. All children outgrow their allergy. Of these children, 17% with fish allergy developed tolerance. Sensitization to egg was a marker for increased pollen sensitization, i.e. allergic airway disease. Presence of asthma symptom and bronchial hyperactivity were not associated with persistence of food sensitization. That means that probably the children were sensitized early on, but they still have allergy sensitization and bronchial hyperactive. And when I did a huge study, a 3-year-old study in National Guard for 3 years, one of the things that we did, we reviewed the all medical record to see what was the diagnosis of asthma, because we were auditing, we were looking at implementation of mandatory pathway, and it was amazing looking at the diagnosis pattern. Some of it is bronchial hyperactivity, this is a doctor diagnosis, some of it is allergic asthma, allergic chest, you name it. And I always say bronchial hyperactivity is not a diagnosis, it's a description of a state of the airway. Sorry. And this is food sensitization in allergy and asthmatic versus non-asthmatic. As I said, children are had food sensitization, and these are the incidence of asthma. This is a famous study done in US, one of the biggest study, and this is the green are the one who develop asthma, and the significance was quite significant. So it shows that food allergy is a risk factor for asthma later on in childhood, and this goes well down the route of the allergic march. And this is why really one of my objectives is to understand very well the allergic mark and to convince you that children may grow out of their symptomatic allergy, but they never grow out of it actually. At least as a physician, we should deal with them like that, taking a good history, taking a focus examination, then we're not going to be missing cases like the one that presented nicely in the previous speech. Right, from sneeze to wheeze, key data. 40% of untreated allergic rhinitis progress to asthma. That's been mentioned. The PAT study, the famous study of SCIT, which is subcutaneous immunotherapy, the one that given by injection, reduced asthma incidence by 44%. relative ratio was 5.59. 10 years past, the past follow-up confirms sustained prevention, i.e. if you give the subcutaneous immunotherapy now, if you do the same, if you examine this child 10 years, they will still have remission from them symptoms. And this is, I would say, I wouldn't boldly say cure, but I would say the only definite treatment now we have is immunotherapy. So focus on immunotherapy and spreading the word about immunotherapy is very important, not only among doctors, but also among policymakers, regional and global health policymakers, because I think we should have equity in health system, and here in GCC and MENA region, they can afford immunotherapy. It's not as much as available as it should be, and as evidence is saying. This is the ECAR study, which shows only using cetirizine lowered asthma event, and it was clear risk for asthma because it's reduced in only house that must sensitize infant. And I will come to phenotype that, for example, when they give the anti-IL-5 to children with asthma, this is off record, which is mebulizumab, anti-IL-5, it failed miserably. But when they give it to children with increased eosinophil, it was a huge success. What I'm trying to say that we're living in the era that we need to know the underlying pathology so that we can target the correct medication, even something like cetirizine. The Cochrane review has proven that allergy immunotherapy is very effective. It halves the risk for asthma in children with rhinitis. This is huge. Nasal steroid improve symptom, but the long-term prevention does control is still questionable, and I'll ask audience to comment on that. Early disease modifying modality is allergy immunotherapy. It does really curb that atopic march. Here, this is where I trained, Imperial College London. This is Professor Noon. In 1990, actually, he did the first trial of immunotherapy. He took progress and he put it into his nose, and then he drew his paper, I think that was in early 1910, 15, somebody correct me here, when he noticed improvement of his symptoms, and that was the first actually trial of immunotherapy. And without this man, who I'm proud to say that I worked with him, Stephen Durham, the blood would have taken from immunotherapy forever. When one child, adult in the United States died from anaphylaxis from injectable immunotherapy, and then studies with collaboration between the Imperial College, the Brompton, and the American has revived the immunotherapy, both sublingual and immunotherapy and injectable. And the rest of the story, you know it, that immunotherapy is now known to, I will say, proven to treat asthma and prevent it, known to treat allergic rhinitis, hence prevent asthma. And also there is emerging evidence that it does prevent other sensitization. And these are the trial asthma incidence after allergic rhinitis. This is a famous PAT study. For these people who do not PAT, is a study that done in immunotherapy, and then the patient followed up for 9 and 10 years. I've mentioned it before, and the efficacy of immunotherapy has been sustained after 10 years. And here, I would like to say that all these studies have been done initially in moderate asthma because of the risk of anaphylaxis before we have the sublingual immunotherapy. But then with the sublingual immunotherapy, and especially again under the cover of biologicals like omalizumab, studies have been done even in severe asthma. So this study has shown how injectable immunotherapy reduce the risk of incidence of asthma significantly, nearly by half. And here is a cetirizine effect in reduction of risk of asthma on house dust mite sensitized children. My call today is, can mild allergic rhinitis lead to asthma in children? We already listened to 2 or 3 very interesting cases of children that suffer quality of life, their parent quality of life, and if there is a time, I would have shown you slides that have shown their cognitive effect. And with that, I'll mention the famous study that has been done in UK among children who does the GCSE exam, the exam that takes to university. And they found that children using cetirizine only, compare them to children with allergic rhinitis not using cetirizine, controlling for other confounding factors like level of school and IQ. They found the children on cetirizine only, they have better results. So we're not talking about disease progression to asthma. We're talking about future potential quality of life and also health. So I will join my voice to the call that has been done initially about allergic rhinitis, that even mild or seasonal allergic rhinitis can lead to lower airway inflammation and airway hyperresponsiveness. Studies have shown clearly that subclinical bronchial inflammation in allergic rhinitis patients without asthma, which predict future asthma. And no wonder now we see asthma, allergic asthma onset at the 30s or 40s sometimes. Children with untreated allergic rhinitis had 2.5 to 3 times greater risk of developing asthma. Again, to general pediatrician, physician, and for health strategy maker, even mild rhinitis does matter, really. And I quite like the link between adenoid and mild rhinitis. I have published a study that shows that children with mild adenoid, they were like 50 children, 40%, 60% of them were sensitized. Out of these 50 children, 60%, when they called them early, was very small adenoid hypertrophy and mild rhinitis, and we used combination of leukotriene and Nasonex. They did not need surgery. Of course, we did not follow up until 6 or 7 years, but those with mild adenoid hypertrophy and mild allergic rhinitis, we can do something about it. Otherwise, we all been through the children that has been big adenoid, obstructive sleep apnea, adenoid taken off, it comes back, taken off again. So really early intervention. My message from this is asthma continuum, allergy disease continuum, and allergy and early intervention. And then it's very clear, the studies has shown that they assess the children with at 5 years who has already established asthma. They found that children with no family history of atopic rhinitis and no family history of A to B and no personal history of eczema, 20.2% of them develop asthma at 5 years old. This is just, of course, equivalent to the risk in general population. The children who had allergic eczema early on, more than double develop asthma at 5 years. The children who have family history and atopic dermatitis, half of them develop asthma. This is why when I do ward round, I tell my juniors that when you go to the ward, just a child who is admitted with wheeze, ask 3 questions. Does your child has eczema when they're really young? And explain what eczema, because sometimes you ask the question, the parent doesn't know what's eczema or what's wheeze. And the second question, ask mother and father, ask mother, do you have eczema or his father? And the 2 cases illustrated before has shown that when the doctor dig in history, actually mother did have allergic rhinitis. And this is really very important slide where multiple early allergic sensitization has shown to be linked to the decreased lung function over time. And I think it's a common knowledge that even if we have a transient wheeze or asthma, childhood asthma, people remain with abnormal function tests for the rest of their life. variability from one person to one person. I personally cannot get into plane without my inhaler in my bag. Although the last time I had proper asthma, I don't remember, maybe I was less than 5-year-old. Even during COVID, didn't have asthma, but I do not fly without my inhaler. And the question is, how late is late? I've noticed when pulmonologists, adult pulmonologists speak, they speak about early 12-year-old, 11-year-old. But for us pediatricians, we do believe that by age 30, maximum airway remodeling has happened already. So late is 3-year-old. And this is a normal airway, this is narrow modeling. And I do say this boldly, refer each child, please, with recurrent persistent wheeze, recurrent admission for allergic consultation. Why? Because I'll ask one question, and I hope that people will answer in the chat box. At what age do you label a child as asthma? And do you have any exception, or is a solid cutoff age? People would say, commonly, if you look at the GINA guideline, they'll say they divided under 6 years, above 6 years, 6 to 12 years. Probably that means under 5 years, you cannot diagnose asthma. And the reason is obvious, because most of the children do grow out of their wheeze, but we all agree that actually they do not grow, is a continuum, but they become better anyway. My personal practice is when we review those records, there are more than 300 records, we agreed to, based on evidence, that if the child has only come, did not come frequently to no recurrent hospital admission, no sensitization, we give the diagnosis at 5-year-old. Prior to 5-year-old, we use what called the asthma predictive index, which now there is a modified asthma predictive index, which is 4 episodes of wheeze. It has to be doctor documented. You have to make sure that the parent understands what wheeze, because the parent has different explanation for the word wheeze. And if it's a child, this is why always I advocate that children, if possible, they should follow up in the same hospital, not necessarily the same doctor, so you can really look at the history. And I think now in Saudi Arabia, they will having the one record, but I'm not sure how does it going to work in view of that data protection. And the question of exchanging global data is now a big ethical question. I think it will be discussed in the Global Health Forum in Dubai, 2026, January. It will be very interesting to see whether we can exchange data for a child who's in India to see whether they have for documented wheeze or not. So one major criteria is parent doctor diagnosed wheeze, not auntie, not sibling. Parent doctor diagnosed eczema, allergic sensitization to an aero allergen at least. That's minimal. I mean, these children has to have either by pediatrician who has allergy experience, or who can interpret it, because like Professor Dharam, I showed you his photo before, he used to tell us that please do not ask for tests that you cannot interpret. It only creates medical legal liability for you. If you cannot interpret the IgE level, do not ask for it. Always refer it either to allergists. I know there is unmet need for allergists, so the children can be referred to pediatrician with special interest in allergy. Plus 2 or 3 main criteria: blood eosinophilia of more than 400. That 400 absolute, but I know that has been now reduced to 300, and I know that has been reduced further to 150, but I don't agree on that. I think this is just probably related to biological use. It's a whole different discussion, but I'd like to hear the attendee comment on that. Wheeze without cold and allergic sensitization to milk or egg or peanut. I think it's justified this because the studies have shown, as I presented before, the allergic sensitization of egg is associated with allergics of pollen sensitization. And I think for peanut, because it's also associated with severe airway hyperactivity, And this is why risk is a peanut allergy is a risk in asthma, in presence of asthma for this and anaphylaxis. But regarding the egg, I'm not totally convinced, probably data that I'm not aware of. The problem now of when we treat children early, we said early intervention matter. We have a huge problem. That lack of evidence in managing acute management of acute wheeze in children and management of recurrent of wheeze in general, different from adult completely. Like the parted children are not small adult because the children with asthma, adult has their constant phenotype. But children, especially those less than 5 years, they visit you each time with different phenotype. This time is neutrophilic, the next time is eosinophilic, and you keep juggling with medication. So unless you have that trust with the parent, they will ask you, why are you doing this? But again, not everybody can do this. There are few medication. What is it? Inhaled steroid, Mentilocas, Tirizine, macrolide, oral steroid. Only 4 of them. But this is not the art. The art is precision medicine. For which child you use what? And even that certain child, at this episode, you do what? I will advise that if the child has severe wheeze, get a CBC and look at the eosinophil count. Because without eosinophil count, the child will not respond to steroid, as you know, providing the child has not been on long-term steroid, because you know that once you give a systemic course of steroid or even inhaled of steroid, the eosinophil will plumb down to 0 sometime. And even the GINA guideline, look at it. I just find it in a polite way, need a lot of work. So they say here, step 1, daily dose of inhaled steroid, and this is, you know, has been moved now. We're not allowed to give any blue inhaler without canister, without steroid, even in less than 3-year-old, although there is no evidence that it works in everybody, and I will explain that. Daily leukotriene receptors antagonist, double low dose of ICS, low ICS plus LTAR-A, ICS frequency, continue. Anyway, all this together does not address the problem. 50% or more than 70% of children with severe wheeze I see in my clinic. And we all know that. It's kind of double the dose, increase the dose, but there is no evidence, as we said, because there is no, the phenotype is different each visit, and there is lack of trial and there is lack of consensus. For example, they study all the modalities. I mean, I do see that we use, I'm interested to know that how frequent do you use oral steroid in children less than 3-year-old? A lot, even in hospital. As a matter of fact, the systemic review has shown no efficacy whatsoever in preschool, even in a reduction of steroid in hospital admission, let alone the new pandemic of nebulizer. 80% of children I see in my clinic with wheeze or even severe rhinitis with viral illness, they are on Pulmicort, home nebulizer. Pulmicort dose, the smallest is 250 grams, isn't it? If you give fluticasone, the highest dose you can give is 800 microgram. As we know, there is a plateau of effect. Let's say 1 gram. Efficacy, we all know, is the same. Again, I think that's a public health issue. We as allergists and pediatricians, we have to address. Prescribing high dose of inhaled steroid to children like Smarties, that's not evidence-based, I think should be really called with, and that's aligns with my initial presentation. Treat allergic rhinitis based on evidence. Start immunotherapy early on. Refer them, because the evidence has shown that early immunotherapy is even more efficient in preventing asthma. And this is a type of wheeze less than 5-year-old. 20% are atopic. This is episodic viral wheeze. This one, they do grow out of the wheeze, and not much of a study about how lung function tests remain. There are few studies, but I'm not totally convinced by them. This is the multiple trigger one. This group remains after normal function test. And even this, sorry. So sometimes the same child can present with this, sometimes present with this. So now when we call precision medicine, because about individualized medicine, and that came from oncology. What suits me does not suit you, does not suit my son who's sitting next to me, fix the Zoom for me. Because we have to look at the phenotype. This is why it's really very important to refer to somebody who can do allergic skin prick test or blood test and can interpret them, away from doing the whole allergen panel and the whole food panel, and then you don't know what to do with the results. Because IgE, as we know, that is just mean that the body is able to produce IgE against milk. It doesn't mean that the child is allergic unless there is a milk allergy. So again, the test needed to be done by somebody, not necessarily allergy, but a pediatrician with a very good experience in allergy to do them and interpret them. And also the other test that can anybody know or look at, you don't have to do it each time. If the child had it 3 months ago, look at the eosinophil count. And this slide is I love it. Look at this, how it's shown beautifully that therapy should be based on phenotype. Here is the blood eosinophil count less than 300, which is not eosinophilia when the study was done, and totally convinced that's still the case. And here was blood when they treat use of steroid in children with wheeze but has no eosinophilia. This is with wheeze but they have eosinophilia. Look at the response when there is eosinophil, because steroid work on eosinophil is significant with a p-value of 0.0071. Sensitization eosinophil is even more, steroid more work, because work on the allergic response, as you know, the allergic response and steroid, and look at the p-value, even half of that. Here, non-allergen sensitization, allergen sensitization, and look at the effect here. Daily use, as required use, interrupted use. I'm not going to talk a lot about this because this is a whole topic. The topic is not a treatment of wheeze. The topic is catching the window of opportunity. Phenotype those children very early. Treat allergic rhinitis very early. Make note of food allergy. Do not say to the parent, oh, they're going to go out of this allergy. They're going to go, don't worry. Because actually, I'm throwing a question even as expert. I do not know if a child is having really a milk allergy. And you insist to do that, to give them milk without a protocol of oral immunotherapy. What is that going to do to the immune system on a long term? I do not know. I'm not aware of studies that say this is safe. If the child is allergic, you have to deal with them based on the evidence available. Asthma continuum, what is the message? Looking at asthma as a spectrum or developmental pathway. It is a developmental pathway. It starts early at birth or probably antenatally with dry skin genetic or flagrant gene, atopic genetic, rather than standalone event. I think the evidence is overwhelming. It begins with immune dysregulation in infancy, which is skin barrier. And this is why use of emollient in newborn has been suggested as allergic preventive strategies. Unfortunately, the studies has not been positive, but I'm still advocated based on no harm, because the evidence may well be lagging behind. Food sensitization is a huge risk, so always make sure that you take a detailed history about food allergy, even though if the parent forget it because the children grow out of it. You have to dig, really have to dig. Allergy is a work of, it needs some time of detective work. End of formal asthma diagnosis with formal asthma diagnosis in all children. Eventually, if you see everything going down that route, do not be shy from labeling them as asthma and refer them for allergy tests and immunotherapy. Fair enough. And if they severe asthma, they need to be referred for other modalities. Continental model suggests that early intervention may reduce severity and may often prevent asthma. And this is well known, that the first 1,000 days of human life is a window of opportunity, not only for asthma, for the brain, for everything. And I quite like this first book from Education World India, when I was looking yesterday, and I find it really very nice, although it's a drug company, but I quite like it. Neutral progression of allergy disease that often begin early in life continues till the adulthood, and skin allergy, food allergy, nasal allergy, asthma, pathway of allergic march. I think it's a fascinating awareness by this pharmaceutical company. I quite like it. It really does align with our postdoc very well. Back to the allergic march and to the $1 million question that already Dr. Sunil has answered, and I'm trying to convince you that is this the allergic march here, the allergic asthma, and I just tried here to put it. Should we intervene here or here or here or here? Would we stop the progression forever? I will say the growing evidence shows yes, definitely allergic immunotherapy carpet here, up here, and definitely treatment of eczema early on is not evidence-based, but with my anecdotal experience, because the children, I'm not revealing my age that I used to see when they're 1 year old in my clinic, they ended up being 9-year-old. I think early aggressive treatment of asthma and food allergy with frequent visits and with frequent follow-up and with communication with the team as in primary health care and young pediatrician has very good result in at least reduce the severity and delay the occurrence of asthma. And this is just further emphasized that, look, this is again the Warner Group, again from Imperial College London, and this is I think a landmine studies that has shown they divided into primary prevention, and this is in common with allergy, primary prevention. Here they spoke of vaginal delivery, breastfeeding, early weaning, and as we all know that the only preventive strategy, which I don't agree, approved by IAP and American guideline, is early introduction of variety of food. They cut off every other thing, waiting for further study. And this is secondary prevention, which is treatment of chronic allergy. Imagine this is rhinitis, early prevention. Here again, remain the same. Advise the parent, vaginal delivery, just to give them informed choice, if it's by choice any. Breastfeeding, advise them skincare, and secondary would be using antihistamine, treat adenoid hypertrophy, use inhaled steroid, and then I would say here, refer to, if it's proven, refer to allergy immunotherapy. This is my own suggestion. I think we can, and look at this here, when we talk about this, we talk about the first 3-year-old. Here we have the primary prevention, the real window of opportunity, but luckily, immunotherapy has given us a second window of opportunity when the children are school-age children. So we should use both of them. But of course, focusing this in terms of global health strategy and cost, this is better. And this is I always show this slide. This is my slide in the Breeze World seminar that we've done in Bahrain a few months ago. That treatment of allergic disease, respiratory disease, the critical role is the first 1,000 days of human life. My conclusion, undeniably, there is a pandemic of allergic. I would use your word, excuse me, Sunil, that there is a pandemic of allergic rhinitis and asthma and other mismatched diseases, including diabetes, obesity, hypertension. The window of opportunity is very narrow initially for all these diseases. However, team collaboration is vital for early recognition and prevention in considered as far as atopic march is considered. I really tried to explain that in depth. How am I doing with time? I have only 2 slides anyway. Modality of allergic rhinitis asthma treatment is a privilege that we should leverage, really. Currently, the AI, IAP, and American Academy of Pediatrics emphasize that primary care provider should not hesitate to involve specialists early when multiple atopic symptoms appear in a young child. This is really very important. We're not looking for referral. We're just looking really for those children to get the benefit of the window of opportunity, because the clinic really heaves when you get a lot of referral of these. But definitely, if the child is recurrent, has a recurrent admission, recurrent A to B, family history of A to B, that one deserves a chance. And finally, beyond asthma, can immunotherapy help with other mismatched disease? Reduce the emergence of any new allergen sensitization, polysensitization in children, that has been shown, essentially to moderate the overactive Th2 response and promote long-term immune tolerance, i.e. bringing Th1, you remember the slide, Th2 imbalance, role in cardiovascular and cognitive function. Does it reduce? And is it a lot of things that the window of opportunity for all diseases very early on with the microbiome and HMO, and when we intervene here, we already reduce the chances of obesity, hypertension, diabetes, and mental health. And I quite like this slide from this journal. I invite you to read this article. It's very interesting, especially in regard to obesity and mental health. Thank you, and this is my contact.
I think the last slide didn't move on. It's in the conclusion, doctor. I think you showed a study which didn't come up.
This one?
Yeah, you gathered as much. Thank you very much, Dr. Manal. It was
As a matter of fact,
very
I would say
nice,
this
and
is
as
my
you promised.
conclusion.
Thank you, Doctor. Thank you, both Dr. Sunila and Dr. Manal. Between you both, you really covered a wide gamut of what allergy-related practices a pediatrician should empower themselves with. The whole idea is to update pediatrician, because they are the frontliners, and to coordinate with allergologists when and how. We got a clear concept as to how rampant the concept of allergy is. Although we all encounter it so many times, we tend to, as Dr. Sunila highlighted, we tend to consider allergic rhinitis as a benign, by the way diagnosis, whereas we understood the importance of being proactive in addressing allergic rhinitis, and how the impact is reflected on so many things apart from the impact on asthma. Dr. Manal exemplified the clinico-pathological overview of how the atopic march, the concept, and how clinically practical impact of understanding this atopic march as such. Now, we will go through some of the questions if there are any. There was one question already addressed by Dr. Sunila. As I see no more of it, we will take some discussion points to address some practical aspects touched upon by both of you. And now that we understand it, it's quite a basic thing, and a pediatrician who's attending would have understood that he has to be a little more proactive in seeking allergy as a background and allergic rhinitis, as it was in the first topic, as well as early as early infancy, picking up atopic dermatitis, food allergies, and the concepts here. There are certain legacy concepts as to what are high-risk areas and how a pediatrician should intervene, how full-scale management of these conditions could avert the next steps. So I have a question first to Dr. Sunila, as she already addressed that question. There was there was a concept where she said incomplete or inappropriate management of allergic rhinitis is what is the future asthma. So she did touch upon the duration, the actual medications which are so. To give a little more overview as to, she said it has to be tailored to the individual condition which the doctor is treating as an allergic rhinitis. Are there any objective markers which would assist a pediatrician to say that allergic rhinitis symptom profile has to be addressed to this duration, like how asthma care says control and relieve. Any controller options are there for allergic rhinitis to make it really something as appropriate treatment. So to just give a little more confidence to a practicing pediatrician whilst he is managing allergic rhinitis. Doctor, I do understand you did touch upon the timeline, but a little more clearer concept. I know ARIA has definitive guidelines, but still there is no guidance has a timeline and how do you titrate, what are the objective parameters you would titrate on. Dr. Sunila.
So the key thing about allergic rhinitis treatment, like say if you've started treatment for asthma, you've started both the reliever and controller, they start feeling better pretty much straight away. Yeah. Whereas in allergic rhinitis, I was telling repeatedly, the cornerstone of treatment is the nasal corticosteroid, intranasal corticosteroid. Intranasal corticosteroid takes time to act. And that is at least 15 days. So bringing them back too early or telling them that, you'll have one of the things that I tell my parents is, I'm going to put you on this antihistamine to try and control symptoms for now while this medicine starts acting in the nose. So it will take a minimum of 15 days. I usually call them back in a month to see if it is working or not. First of all, are they responsive or not? That you assess for about a month, which gives them 15 days of the medication having started to work. Yeah. So it is usually started with, if you want me to share the screen again, I can try, but it is quite, so you will start with the intranasal corticosteroid and the antihistamine, and you will review. Once you review, you see how things are. Now remember, this starts slow and it takes time to work. So I wouldn't rush in bringing it down. So just like how in asthma, we say Budecort or Foracort, you would give for a good 3 months before you consider bringing it down. You would possibly give it for 3 or 4 months and then. But the thing here, I wanted to say, and this is very, very important, is in your history, you would have possibly come across the key triggers. So if it is nighttime trigger, like every morning I wake up with a problem, or at night my nose is blocked, or at night I cough, so at daytime I'm fine. So maybe it is dust mite, it is in the bed and that's the trigger. No, I go out to play, I come home and my nose is congested and I'm sneezing, and every time I go out I have this problem. My eyes itch when I go out. So it is most likely an outdoor allergen. So there you start becoming more precise in trying to identify where the culprit is. If it is something indoors, it is usually perennial, meaning all year round, and it may get worse during certain months of the year. In India, we'd say monsoon, but I'm sure out in wherever you are, like in Bahrain or anywhere else, it depends on the local weather, because the more humidity there is, the more likelihood of dust mite. Okay. Whereas if you come to pollen, you need to have a fair idea of which pollen are prevalent in which seasons. Now, in UK or in some of the countries, you get in your news channel, they say today the pollen count is high, today it is peak, or today it is low. So you get these pollen counts, but we don't have any such thing in India. So we need to know the seasonality of the pollen, and you may need the treatment only in that season if that is the pollen that is a problem. Say, for example, in India, we have a very common weed called rhinitis, which really, there is a lot of itching in the eye, and the children, adults, everybody who gets it, and it's a very common weed. and it intensely affects the eye. So definitely before the season starts, you would start treatment and you would continue till the season is complete and then stop if required, if there is no other sensitization. But more often than not, you see polysensitization, and based on when the severity is, you would take it further. If you have to give it all year round, not a problem. But don't just give it and say, there you go, you have your intranasal corticosteroid, you keep taking it. We do need to do the next steps, which is a test, doing an allergy test, identifying the allergen, doing the avoidance measures, and starting immunotherapy, at least giving them the choice of starting immunotherapy.
Clear. What's by 1 month when you review, if you don't see adequate response, what's your next step?
You have to go back to history, review the whole thing. Have you got the correct diagnosis? Look at the the other differentials for whatever it is you're treating. So rhinitis is not all allergic rhinitis. There are non-allergic rhinitis too. And if it is one of those, especially if it is one unilateral rhinorrhea, or if you have thick mucus, thick yellowish discharge, it could be polyps, it could be CSF leak, it could be many other things. So look at your diagnosis. If there is no response at all, but first, before you do that, check compliance, check technique. Quite often, children don't, you might have told them, go, point to the outer corner of the eye. So it has to go laterally, but they go like this and go medially. And that will not give them enough symptom relief. So ask them to do it in front of you. You may pick up, quite often you pick up many technical issues, like, the technique is not right, or they have not been taking, compliance is very big. They take for 15 days, they start feeling better. The child stops taking, doesn't tell anybody. And, those kind of things are important. So always, just like you do in asthma, assess, see if it has not got better. First, check the technique, compliance, and see if the dose is adequate. See if there is a lot of mucus. Do they need a saline spray to blow out the mucus before you put the spray? These kind of things are very important, because if there is a lot of mucus there, then the medicine will not reach your turbinate. It will go on the mucus and go out. So that is why saline.
So there is a concept of step ladder, like if you don't see adequate response, do you increase the dose? Is there a concept of that as well?
And that too, you can have different molecules. You have mometasone furoate, you have fluticasone propionate, you have fluticasone furoate. So if you want to, you can try with a different molecule, and it does make a difference. Some people respond to one molecule better than the other. So that is there. But you have to be certain that you're using, even with a different molecule, you will get
making sure.
You will get a little bit of response. If they say no difference at all, think very carefully whether your diagnosis is right.
Okay. So whilst on intranasal steroids, when is the appropriate time for allergy testing? Well, would that matter? Would the treatment matter? Would it reflect the appropriate sensitization and such?
So, it doesn't make any difference to the sensitization. So the allergy test is based on histamine response. So you get a wheal and flare response. If you have given an antihistamine, and that to your second and third generation antihistamine sometimes stay in the body for a long time after you've taken it. So 5 days, I would say 5 to 7 days gap should safely cover most of the antihistamines that we have like today. And so unless you have given that, you may have no response at all, because your antihistamine is blocking the histamine response. So it's pointless. So always ask. Now, the other thing to make sure, we ask antihistamine, but there are a lot of alternative medicines also that people take because they don't want to take inhalers, steroids, spray, nothing. They will go down the homeopathy, Ayurveda, all that road. And if they have taken that too, sometimes affects the skin prick test. So there are obviously antihistamines in nature which are being used as treatment in the alternative medicine. Medicine is medicine, whatever you call it. So it is going to interfere with this. So my standard thing is no oral antihistamines, any antihistamines, oral, topical, everything will affect. So no antihistamines for 5 to 7 days, no Ayurvedic, homeopathic, any other medication orally also for 5 to 7 days.
Yeah, clear, Doctor. Dr.
And
Manal, would you like to join in here?
yes,
I
actually, I
noticed.
have. Thank you. I totally thank you again. You emphasize on how really allergic rhinitis is such an important disease, especially when it's linked to adrenal hypertrophy, sleep quality of life, and in my view, the progression. I have here two questions. Number one, some of the global experts saying that uh, we should have a polling count. It's a must-have in every region. And as you said, we have no data even here in Middle East, in India, in the region. We have no data about the actual polling count because some of the guideline for omalizumab, we really say to you seasonal allergen, but actually some of the allergen here, like Russia and Sicily, the season lasts for nearly 10 months. So that's annual allergen, not anymore. If we really need a polling count. This is a comment. My question is, what do you think about a use of in severe rhinitis? What do you think about using of a push-off a systemic steroid? Because it takes about a month to 6 weeks to take over, and that sometimes affects the compliance. And again, I did not hear you commenting about the combination of Mentilocas adding on antileukotriene, Mentilocas, if the child is not responsive to nasal steroid. And the last question I forgot.
Okay, I'll start.
Okay.
answering these. If
She'll
you-
gather the
the last.
answers in the meanwhile. Dr.
So I
Sunita, please take
actually
the
didn't
answer.
go into the detail because of the time constraints, to be honest, because Montelukast is such a popular thing. It's really literally given out like sweeties. It should not be, but it is. These are all additional drugs, these are all. The reason I stress so much on intranasal corticosteroid is that's the one thing people don't seem to use. They use everything else. They use oral antihistamine, they oral decongestant, nasal decongestant, anything and everything is started. So I didn't stress too much. But yes, Montelukast or anti-leukotriene agents are very good in that some of those mediators are directly help, and it works for both mild asthma and mild allergic rhinitis. It makes a good combination. So it's a very good medicine as long as it's used appropriately. Okay. The second thing is what we get in India is a very common thing is it's a combination with an antihistamine. I don't know if you have it that in Bahrain, but I am not very keen on that. I feel if the child comes back with not having, responded to your nasal steroid, and then of course, first go back, make sure the technique, the compliance, everything is right. Two, definitely make sure that the history and what you're treating match up, make sure your diagnosis is right. Then you can see whether you can add on medication. The add-on medications, the first one would be Montelukast. Second, if it is really severe, completely blocked, nothing else is going on, you can even try a combination of intranasal corticosteroid with an intranasal antihistamine. There are combinations available, and that works too, topically, and that is quite quick. If required, you can add on an oral corticosteroid, a short course, 3 to 5 day course of oral corticosteroid to just bring that inflammation down. But you have to be very careful when you give it to the patients or the parents that this is only for now and this is only on prescription and only I ask you to do so. Because I've seen a lot of parents feel, oh, this really worked well, I'll give it. We have the problem in India where you can just go and buy whatever you want from the chemist. You don't always need a prescription. And if you've had a prescription from before, people will give it on that also. So that is why it is very important here to stress that this is not something that they should take it on their own as they please. Because as you saw with the second case that I showed, they were self-medicating with anything and everything. Did I
At this
all your
point,
questions?
yeah, you did cover. I think, Dr. Manal,
I think
do you have the third question in mind?
No, I just want to say compared to the patient here in Bahrain, actually parents are very reluctant to use systemic steroid when you prescribe them. So we don't face that problem. You have to convince them, especially
So
for young children.
Here it is both.
Yeah.
You have some
Yes.
who are so worried about steroid, they
Yes.
want the nasal steroid. And then
Yeah.
there are others.
Once they see the response, they might get reassured by, falsely
Exactly.
reassured by
Yeah.
the spurt of response. Now, at this juncture, I would like to invite some comments from both of you regarding the neuropsychiatric adverse events of the LTA. So, where does it stand? Now it's losing its popularity because of this, and how objectively can we, in less than 2 years also, we see Montelukast being started? How can you supervise these symptoms, and what's your experience of neuropsychiatric adverse events when this is started, and your take on how and when to go about?
So long ago.
I see a smile on Dr. Sunila's face, so please take
Yes.
the
Yes.
question.
Yeah, Montelukast, long ago when it first came along and there were studies being done, I was part of one such study while I was in the UK and working. And it was being tried to see how it will work for viral induced wheeze. Even then, there were a couple of babies, less than 2, who, as soon as you gave the medicine, they would get very hyperactive. They would do things that, and also there were very occasional. This was extremely unusual, but it was there. Even in that small cohort.
Sleep disturbance.
Sleep
disturbance.
Nightmares, night terrors. They would wake up and have nightmares. So as a routine, I always tell them that this might happen, and if it happens, you stop. You don't continue. I tell them routinely from whenever it was that I started prescribing, I tell them. Later on in the adolescence, the suicidal tendency, the depression, and other issues have been highlighted. I feel it is still a very good drug. It is still a very good drug, but it has to be used in the correct way. There are 2 things here. One is that only some people respond to Montelukast. So you have a genetic susceptibility to whether you respond or not. So based on that, when you first give, I always ask them, remember if you do feel better with this or not. If it makes no difference, you need to tell me. So in such patients, I don't think I bother continuing with that for any. But if it does make a difference, I use it as a brief add-on where it is required, when it is required. And I always give an end date for it. You are using it only for a month, only for 15 days, while all these other things start working and making their presence felt. So I do use it. It's not
Manal, your experience.
Yes, because I do use it a lot in adenoid hypertrophy, and we less use it now as a first line, as you said. It's why I ask about add-on, because I think it's just I think in allergic rhinitis in general, if you stick to if the compliance is good and the way the Nasonex or other, I stick to Nasonex because of systemic absorption is used the correct way. Actually, the number of children that are resistant to treatment, in my experience, is not that huge, providing that you really do the thorough history, you demonstrate how to use them, and you improve compliance, you make sure they're using it. Montelukast, the studies have shown that severe symptoms does occur in less than 2% of the population. And before the social media, my own practice was that because I've seen one child only with severe symptom, that not to describe it to the parent because in my view, the studies in neuropsychiatric, there has a lot of confounding factor in teenager. You cannot say it's all due to Montelukast. I read them and I've seen how they choose the patient. You cannot say 100%. So the way I used to do it is to give it to the patient as an add-on therapy, and then give an appointment, and then ask in another way. Because nowadays every mother is thinking about ADHD and hyperactivity and sleep. So once you mention it in the first visit, I can guarantee you that they will come and say subjectively. So I don't know whether people disagree with me or not. I give it, and then I ask about in this follow-up visit, I do ask in detail about sign and symptom of this complication. And if, of course, eventually I do explain to parents when they're really comfortable with it and they're not mentioning, so that even if there's mild things in retrospect, they will say it. This is my personal approach to neuropsychiatric and monthly CAS. And I think we should really practice in the era of a podcast of social media. Yeah.
Yeah, whether we tell them, school them about the symptoms and not, they're quite aware. I think it
I'm talking about
becomes,
young children. I'm talking about young children. If
Yeah.
they're older, less than 4 years, because by definition they all have ADHD part of the. But if they're older, and we need it as add-on therapy. This age group, I do touch on this, highlight on the first visit. I do touch on the studies and giving them actual reported data, like 3 to 6% is mild and less than 2 is severe. But in younger children, you know how it's really difficult to deal with young parent, first parent, always.
True. Yeah, but it comes with a box warning already. FDA has given a box warning,
I
and
know,
then
I know. Absolutely.
so
I know. This is why
it
I
becomes
say
very difficult to
yeah,
talk to
yes,
them
yes.
about it. Yes, yeah. And
It's
particularly
first,
towards allergic rhinitis, right? They
Yeah.
dissuade us to use it as a
I do
single
it a lot
medication.
on adenoid hypertrophy, because I think it is really worth a shot. Because if you review the literature, you'll find this is a consensus, and the study has been shown about 20 to 30%, up to 30 reduction of need of steroid. I'm not saying I'm not mentioning. I'm just saying I don't really focus it. I just mentioned that some side effect on the box. If you look at it, and then next time I ask in details. But for children older than that, I definitely mention it. And the other thing I do mention as well is antihistamine, the type of antihistamine. Although they say, coming to that warning box, although the cetirizine come with a warning box less than 2 years, where first generation does not come in a warning box. We already know the data have shown that first generation is more dangerous, a risk to even deaths than second generation antihistamine. And therefore, I'd like to say here, please do not use first generation antihistamine even in young children, because their side effects are more than the benefit. Cetirizine is more safer, and I'm not sure what is your take on that. This is common using first.
Conceptually, pediatricians are moved away from first
Cetirizine
generation.
comes with a warning box. Imagine it. Most of the most antihistamine that has safety data in children is cetirizine.
If they have a query, we can explain about the safety.
Yeah.
I think
Yeah.
pediatricians have, by and large, moved away from first generation
Yes.
antihistaminics. Yeah.
Yes.
Yeah, it boils down to the concept of precision medicine, where a group might be responsive, a group might not be responsive. So it's about review and make a judgment as to, do you really have to pursue? So when would you review? When on monthly cost? So what's the timeline? A month, 2 months, 3 months?
I see them in 2 to 3 weeks. Once I start monthly class, I
To
see them in 2 to 3
judge
weeks.
the effectiveness, and if you
To
say
judge the
things are
effect,
not effective, would
for
you
3
discontinue?
No, I would give it another. I'll decide. I always decide after 2 months. Number one is the compliance.
When will you
because it
decide
should
it's
be
not
given-
effective?
No, but that need a lot of teaching. I mean, that need a lot of teaching, and whether they use it every day or not, whether they chew it or not.
Yeah.
I mean, the 2 weeks.
Assuming
effectively,
compliance, assuming good compliance, we have
Assuming compliance, I think-
lent on, yeah.
If there is a case of adenoid hypertrophy and rhinitis, I will give it a couple of months. If it's only rhinitis, I will just withdraw it because of the side effects. And one thing I would like to add on those resistant, especially less than 18 months, in my experiences, if you rule out everything, think about sensitization to milk allergy. A lot of cow milk allergy present with symptoms similar to allergic rhinitis. You cut the milk and you get a response.
That brings us to the question. We are talking atopic March, and there are concepts in prevention of allergies also. So we have high risk and situations of high risk, the concepts of when to introduce. You did touch upon the weaning, early weaning, when to introduce high allergenic food in high risk patients, and when to do the testing in high risk patients who are not manifesting with allergy symptoms, and when we gathered that a good atopic dermatitis care, good emollient, would serve to prevent or arrest the atopic march. But amongst the food allergy, these would be the queries. When early weaning, what is early weaning? And when would you, what are the evidences that there are new evidences? It was a concept to avoid allergenic food for a long, long time. Now the concept is early introduction. So give us the recommendations, give us the guidelines, which in this context would be useful for us to know what is early introduction of peanut and what is the risk category and what is early introduction of egg in a non-sensitized patients. And another question, what's the earliest time you would start on immunotherapy and what is the status in Bahrain? And when we need to refer for immunotherapy, what's the path for us? Both of you, please take back-to-back questions. And there is a question in the chat box. I will read that after this. So Dr. Manal, about
right.
food
So,
allergy, introduction, weaning, and introduction of
as-
peanut and egg.
Yeah, I think we've seen a huge shift in the recommendation regarding allergy prevention post-COVID, even. Initially, there was a partial hydrolyzed formula, this and that, but now actually, like I said, the only proven thing that is to give diversity food, even allergenic food. There is nothing such as allergenic. I think this is evidenced by the LEAV study. The earliest you give it, the better is the outcome. And if you ask me when is to give it, I normally advise by them when the child is exactly finished. People will say 4 months, but I think to be really safe, I would say by the end, when the child hit the 5th month, because then the mucosal leakage in the gut is more mature, so there isn't a much mucosal leakage. I would say beginning with the 5 months to the high risk. And come here the high risk infant, because all the systematic reviews that has looked into allergy intervention has used high risk infant study. But then what you look into them as individualized studies, you've seen that there is no consensus about who is high risk. Is a high risk the one with family history? Is a high risk with the one who is eczema? It's really bad. And if you look at the allergic march, from the evidence, if the child has eczema, if you do IgE peanut, they will be positive if mother touches them. So I think unless in my personal approach to very high risk infant with the children, siblings, anaphylaxis, I will say start early, but start carefully for practicality. I will say start with a small dose, like a lip dose, and then a tug dose, and then don't give various food. This is the very high risk group. Don't try various food at the same time. Like don't give me the child a mixture of egg and fish and come to me, the child develop a rash. Then if I do a specific Ig or skin prick test, he or she will be positive to 4 of them. And then I wouldn't be in a ground which to advise. So I'll ask them try one for a week and then move to the second one. This is by the time they're 5, and try with a very high risk like family history of anaphylaxis, try with a lip dose and then a tongue dose and then 1 spoon, and then, but definitely don't try multiple food together at the same time, because a lot of children, they come to you, we had a food from outside, it had cashew, it had milk, it has egg, but we don't know what is it. You test them, they're positive for everything. So the aim is to avoid unnecessary restriction, because it's a huge area. Unnecessary restriction, growth, and also psychology of food, taste, and everything. What was the other question? And then oral immunotherapy. I know some of my colleagues does, some of people in Gulf, some clinic in Gulf, does oral immunotherapy. I do not do it because I think it is still, there is no standardized guideline. It's still it's still in clinical trial, and until now we did not see the carry-on effects that we saw in allergen immunotherapy. i.e., if you give the child immunotherapy for egg or peanut, would it last for the rest of the life or the moment you cut? The only thing I do, if a child has multiple food allergy, I will do that to improve the quality of life. I do that under the cover of omalizumab. If they're allergic to everything under the sun, you know, the child becomes allergic to everything, egg, potato, you see those children. In those cases, if they're like 3, 4, if they're more than 5, we give them under cover of omalizumab to reduce, to improve quality of life. But I do not use oral immunotherapy because there is no standardized protocol for it that I'm convinced with yet.
Yeah, but there are recommendations for slit and
Can I
skid.
just ask one question, Dr. Manal?
Yeah.
Yes.
That you
Skit, yeah, but not the sublingual that done locally, giving small amounts, especially in young children.
At home.
Because,
Under
yes,
supervision.
because at home, unsupervised, there is no evidence that there is carry-on effect, even if they grow out of it. There is no evidence. So you're putting them at high risk, unsupervised, and then weighing the risk against the benefit.
Can I just ask a quick question, Dr. Manal? You said you
Yes.
give them food, if they are multiple polysensitized for different foods, you would give them immunotherapy under the cover of omalizumab, correct?
Yes, and not immunotherapy. We'll try to introduce some of the most important element of the food, because for some people, if they're allergic to wheat, egg and milk and potato, what option they left with? Some children are like that, you know.
Yeah.
But then there is
How long would you give the omalizumab?
The longest we've given it like for 3 or 4 years, and this is not a lot of cases. This is like 3 or 4 cases. The results was very good.
But that is
In
every
terms-
month, huh? Every month you would give
That's
that.
every month, yes. But this is need again collaboration. Parents that really convinced and very keen, because you have to give the omalizumab at hospital,
Correct.
as you know, it is not like the big cent. But I think in cases of children with everything allergic to, that's justified.
Yeah.
And the morbidity also, the manifestations, if it's severe asthma and severe allergies and all.
Absolutely. And you find that their asthma improves, their attendance to ER improves. But the issue is that you cannot do that in every setting, because the insurance has to agree on that, and also the parent has to be happy if the insurance refuses to pay, because you have to prove it's a severe asthma and fitting all the boxes.
Thank you, Dr. Manal. Dr.
That's a
Sunila,
caveat of
your
it.
take on the food allergy prevention, or
The one thing I
the
tell,
whole allergy prevention by food introduction.
yeah.
There have been studies, leap and eat and such. What's the concept? How would we counsel our parents when they come to us,
First thing-
especially if they're high risk and they're themselves not sensitized? So how do we
Correct.
go about it?
So in high risk patients, well, in everybody, but especially in high risk patients, where there's family history of allergy, so you know that the child is at a very high risk of atopy or any allergy for that matter. The one thing I always tell them is don't put anything edible on the skin. It starts from there. They get sensitized because sometimes something enters through the skin, and that is one way of sensitization, whether it is milk. There is practice of putting ghee, malai, olive oil, mustard oil, besan, sesame, you name it, they have put it on the child's skin. And generally you see that they have used that on the skin at some point, and the child has gone on to develop sensitization to it. So I'm not saying that everybody who has that will develop a sensitization, but in high risk individuals, if you want to advise about avoiding allergy, one of the key things is try and avoid anything edible being applied to the skin, especially in dry skin, very, very, very important. But even otherwise, I would advise that. I will also agree with Dr. Manal that variety is key. Variety is so, so, so important. Non-processed food, variety, the same food that the family is eating at home is what I would suggest rather than buying ready-made baby food. So whatever the rest of the family are eating, you cook together, take some out before you put salt, sugar, masala, whatever, and then keep it aside. And so everybody eats similar thing. Give only one food at a time which is new to the child. Never introduce more than one at a time, because if there is a problem, then you don't know which one the child reacted to. There is this debate whether we should start as early as 4 months, whether we should start at 6 months. Right now, the guidelines say that at 6 months you start. So I think little bit you also judge based on how well the child has developed and the milestones, and whether the child is holding their neck, sitting up, all that is also important, whether they are very keen. But in a high risk
The
individual,
question is the introduction of peanut, exposure to peanut,
I
exposure
wouldn't
to
consider
egg.
it any different to any of my other things unless I feel that it is very likely. So they say that, you know what, somebody was eating peanut and his atopic dermatitis flared up. Or there is some such thing. If they have severe atopic dermatitis, which seems to be flaring up without any reason, then I'll be very cautious. And sometimes if there's somebody's had anaphylaxis, they have severe atopic dermatitis, which you have no idea what the trigger is. You've done all the usual avoidance, but it's still not working. I may even do a serum specific IG just to give me that additional sort of support in when I introduce and how I introduce. If it is very high risk, as Dr. Manal said, I would never ask them to give it just like that, a very little touch and see if everything is fine, then go ahead, but touch to the lips, not to the skin. So that is also very important. And lastly, if the parents are also very scared and if it is very high risk, I might as well do it while, in presence, you bring them to the clinic or something, and not as a oral food challenge, but you would do it there. So in case something happens, we are there. And if anaphylaxis is there, we treat it. We are talking about IgE-mediated allergy, aren't we? So IgE-mediated allergy is the only thing that will give you anaphylaxis. And if you're worried about anaphylaxis and it's IgE-mediated, it will happen if you keep the child in clinic for half an hour to, whatever, half an hour to 2 hours, depending on how severe or serious you think it is, then you will be all right. They can come, they can, the child can be playing around and they feed it a little bit, stay there, and then go home. If this I'm talking about very high risk, no sensitization, it's just the entire family has atopy and they're worried that the child will have, but it doesn't always
No,
work.
the concept of desensitizing by early exposure. Are we there? Are we advising desensitizing by recurrent early exposure?
You want to desensitize? No, I would say you would introduce it and start using it as food. That itself is desensitization. See, if you eat something
instead of avoiding, expose early, would that be a good idea?
Yes, the key here to remember is through skin, it is IgE. You get sensitized. Through mouth, if it is the first time and you are not a sensitized individual, if you eat it through mouth, you produce more IgG. So you get more tolerant.
I think regardless of the high risk or there is no risk, we're not talking about desensitization. The whole idea, we're talking about tolerance, training the immune system, moving away from avoidance. Because the studies have shown that if you advise mother to avoid food, there is no way that minimal allergen can cause. So we're moving
do you emphasize on that concept as an advice?
Absolutely. What I advise is training the immune system, regardless the child has high risk as in family history, give a diverse diet. Even if you Google it now, guideline, you will find the only agreement is give a diverse diet. And the studies has been done as early as 5 months. I think the 5 months is the right time. If you want to delay to 6 months, it's okay. But do not also forget this mother is the first mother, then she will be pregnant again. Promote breastfeeding, promote skin
that
care.
brings to an interesting question somebody has asked here. What are the ways to lower asthma or allergy in the next coming children? if somebody is already asthmatic, if the next sibling, are there ways of preventing this? Is a question that's been asked.
I think
Do
there
we
are,
have any proactive measures to be able to?
I think
Yeah.
there
Yes.
How would you want to take this question?
are, there is a thought process and there are studies looking at the way things are from the time the mother is pregnant, that 1 year before and after birth is supposed to be the most important in how your immune system responds and reacts to things. So there have been
1,000 days Dr. Manal was talking about. Yeah.
it also is from before, not just after
Yes.
birth. So
No,
before
the 1,000 days, Sunil, is referring to pregnancy.
pregnancy.
To
Okay.
the 1,000 days, yeah.
Oh, fine. All right. So I'm sorry, I mistook that. So essentially, things that we know are if there has been a pet while the lady is pregnant and during the first year of life of the child is more protected. Yeah. Pet inside, especially, I think there are studies looking at dogs, which are as pets within the household, and they have been there during pregnancy and also in the first year of life. They seem to have protective. But I think
Effect.
the question in the chat box is how do you lower
Yes.
asthma and allergy risk in the second child in a family who already has somebody with asthma? So I wouldn't suggest they go and buy a pet after this because we don't know what the older one will develop allergy to. So I'm saying if there is a pet, then it is a good thing. I wouldn't say go and get a pet when there is already one child who's allergic at home because you don't want them sensitized and then have problems with that. Okay. Second,
And be a little more proactive, like how you said. Yeah.
so decrease processed food, decrease chemicals at home. Try and make whatever your curd, yogurt, batters for dosa, idli, sardo, whatever else. If you can do that at home, that has been shown to be quite protective. There was a study done in India by Dr. Mahesh in Mysore, where they looked at the sensitization pattern and what is protective. They found that less processed, more, rather than buying your curd from outside, you get the milk and make the fermentation at home. That we are still awaiting proper studies about microbiota in allergy, but this has also been shown to be protective. I'm not saying it is a done deal, but if you are trying to reduce the risk, that is, it is also. And then obviously, since COVID, we have all gone a little bit crazy with sanitizers and stuff cleaning the home. So we don't need to clean 99.9% of the germs from everywhere. We need some of those germs. They are good. And that is where the
Hygiene theory.
hygiene hypothesis comes into play. And the lastly, because right now there is more and more nuclear families, exposure of children early on to bugs has become very, so even having siblings has been shown to be protective because siblings go to school or play groups and bring bugs home and give them to the younger child, and
Exposure.
there's an immune system is being trained how to deal with and how to recognize the right from the wrong and the good from the bad. And that is in a very indirect way. There is no one thing that you do a holistic approach. That's my take.
Thank you, doctors. I think we have taken the discussion quite
Can I just add to
interestingly,
that?
Dr. Manal.
I think
Yes.
Yeah, I think allergy prevention is my area of interest, especially the intervention in the first 1,000 days of human life. As Dr. Sunil said, having a bet, I think this all came from initial study and hygiene theory that children who live in a farms are less prone to have allergic diseases compared to children living in inner city, and that because they are exposed, and that children who are go to nursery because exposed to recurrent gastrointestinal and flu, they are less prone. So the whole thing that linked to this is a microbiome ecosystem. So I think what I advise, and one of these I use it boldly because I do believe in it, because the evidence is lagging behind, but then I use the golden oath that is to do the best to the knowledge available and do no harm. So number one, I always advise the mothers when they come, I ask them delivery, I always take this history, and I said, you know that if you have a second child and if your boss has allergy and your husband has allergy, the chances like 30% the child will be the same. And then she said, what would I do? They asked that. I would say, I mean, if you can avoid vaginal delivery, breastfeeding, but then there are skincare, so it's not proven, but it doesn't harm. It does make sense, because if skincare reduce steroid and reduce eczema, and eczema at the beginning of the allergic march, that means controlling the eczema, maybe prevent the allergic march from progression. And the other thing is maintaining biome, as Dr. Sunil said, no processed food, breastfeeding. If breastfeeding not available, we can really bravely say that there are companies that produce milk that contain prebiotics and contain HMO, human HMO, and HMOs have been shown huge role in allergy prevention. If you cannot breastfeed, or they come already not breastfeeding, I will also advise that. And then again, I will try partial hydrolyzed formula if they tolerate it, especially if the child came again diagnosed, to me already diagnosed with milk, I'm not convinced. And finally is, as like I said, I repeated, introduce food solid, and it really takes, it's a 15 minutes consultation, honestly. So you really have to be generous if you are interested in that. It's not then a 10-15 minutes consultation to advise the mother about the second child or she gone pregnant. It's you've got to have the time and the passion to do it.
Noted. Thank you, Dr. Manal, for that comprehensive answer. Okay, I think we have actually taken the discussion for quite a long time. That must have been interesting discussion. Thank you very much, Dr. Manal and Dr. Sunila. If Dr. Mohammed Salman is around, I would request him to deliver a vote of thanks. I understand that he had his clinic today. I'm not too sure if
Yeah,
he's around.
sorry, Dr.
Yes,
Vanitha.
Dr.
I'm
Mohammed
sorry for
Salman,
Dr.
can you?
Sanil and Dr. Yeah, today is a little bit, I'm busy in the clinic. It's me and Dr. Marcel here. Clinic is so busy, so I cannot fully attend. I attend most of the speaker talk, and I think it is one of the best talk in allergy and asthma that I attend. I know Dr. Manal experience, and we're always happy to invite her and to listen to her talk. She have a good experience on allergy and immunology and all the related disease. And I think Dr. Sani also, she have a very nice presentation.
Absolutely.
Yeah. Thank you, Dr. Manal, and
Thank you, Dr.
it's our
Muhammad.
pleasure
Thank
talking.
you.
Yeah.
Thank you. Honored to have you.
And
Thank you.
yeah, Dr. Snila also. And we always, every year, we're having one workshop. I think this year we will make a conference. It's called Breathe Well. It's only about respiratory update and respiratory care. So I think we are happy to have both of you in the coming event, Breathe Well.
Thank you, Dr. Mohammed. Thank you, Dr. Manal. Thank you, Dr. Sunila.
Thank
It was
you.
really an
A
interesting
marvelous moderator,
overview.
I have to say. A marvelous moderator. You make it really interesting.
Thank you,
Thank
Doctor.
you.
It
Thank
was an
you.
interesting
Thank
co-discussion. So it was indeed a nice discussion today. And thank you, audience. Before I forget, for sticking on with us,
Yes.
and I'm sure you
Yes. Thank you.
benefited
Yes.
from the discussion after the presentation as well. Thank you all. Until the next month. Bye. Catch up again next month. Thank you. Bye, everyone.
Bye, everybody.
Ma'am, can you please end the session, ma'am?
Yes, Doctor.
Vanitha, ma'am? Yeah, please end the session.
There are lots of thank yous coming on. Bye, everyone.